A very good evening to all of you. It is my great pleasure to welcome you all to this second webinar of the year 2024 of the Indian College of Anesthesiologists, and I am extremely privileged to be under the tutelage of Madam Dr. Jayashree Sood, and I welcome Madam to deliver the inaugural address. This webinar is a very useful webinar on cardiac cases. Madam, please.
Thanks, Uma. Thank you so much. Good evening, everybody. And as she says, welcome to the second webinar of the year. I'd like to add another one is a big welcome for the 182nd consecutive webinar being conducted by the Indian College of Anesthesiologists. As you all are aware of the Indian College, that has been running successfully for the past 15 years. And we do total we are interested in academics only, and the 182nd webinar, and we have been talking about various topics, and PG discussions have been taking place. Webinars have been conducted in different topics, which have been of great interest, and we have got different teachers who have been participating here. We, as a college, have also hold national conferences, and this year, in the end of the year, we shall be hosting the ICA Con in Lucknow. Dr. Monica Kohli is the host. We also publish the yearbooks, and our latest yearbook is available on the pustak.com, marypustak.com. So today we have a very interesting PG Assembly, a PG session, in which we have stalwarts who will be the moderators. I shall introduce the first one, the main one, that's MANJULA SARKAR. Dr. MANJULA SARKAR is a very senior cardiac anesthesiologist in Mumbai. She is known nationally and internationally. She is the professor of anesthesia as of now in cardiac anesthesia in the DY Patil School of Medicine, Navi, Mumbai. Earlier, she was the HOD in the KM Hospital. She has several honors and awards. She has authored books in cardiac anesthesia, as well as she runs a journal research and innovation in anesthesia. Of course, cardiac anesthesia is her main specialty. She's a very senior member and a very important member of our Indian College. So Manjula, could you please take over and introduce our other examiners as well as the PG students? Thank you so much.
Thank you, ma'am. Dr. Manjula, ma'am?
Yes.
Yes, Manjula, you may start, please.
Yeah, okay, fine. Thank you, madam, for your kind words for me and my students. And as all of us knows that today's we are going to discuss two cases. One is Dr. Amit is going to present mitral stenosis case, and second is Dr. Aditi is going to present atrial septal defect. For these two cases, the moderators are Dr. Rajesh ARYA. Dr. Rajesh ARYA is a very enthusiastic, dynamic, young cardiac anesthesiologist working at Ludhiana Medical College, and his special interest in echocardiography, transesophageal echocardiography. He has published the book also. Echo Library is under his guidance. And today's second moderator is Dr. VAISHALI MOHOD. She is working as a professor in the Department of Anesthesia at JJ Hospital, Mumbai, and she is going to moderate the session for this Aditi and Amit. So, I invite Dr. Amit to present his case as a first case. And it is going to be long case, and after the case, the discussion will be there from the moderator side. So, Amit, you can present.
Good evening, respected faculty, and thank you, ma'am.
Recording in progress.
My case is a case of mitral stenosis. A 36-year-old male from Navi, Mumbai, auto driver by occupation, presented with the chief complaints of breathlessness since 3 months and palpitation since 3 months. Uh, the
Can you
complaints
make
of
it full screen?
yes. The complaints of breathlessness. The breathlessness was aggravated on exertion. It was insidious in onset. Grade it was gradually progressive and it relieved on rest. It was of NYHA grade 2. Breathlessness wasn't associated with orthopnea and paroxysmal nocturnal dyspnea. Palpitations were present at rest and aggravated during exertion and relieved on rest. He didn't have any complaints of history of syncope. In the other history, he didn't have any previous history of rheumatic fever. History suggestive of subacute bacterial endocarditis, no history of chronic cough or hemoptysis, no history of pedal edema or ascites or upper quadrant pain of pain abdomen, no history of embolic episodes, no history of easy fatigability, no history of dysphagia or change in voice, no previous history of tuberculosis, jaundice or asthma, no history of allergies, no history of previous hospitalization. He has a history of coronary angiography which he underwent on 6th of December. In the personal history, he had a mixed diet. Bowel and bladder habits were regular and normal. He had adequate sleep. He was alcoholic, which he stopped 2 years ago. Currently, he was on tablet digoxin to 2.5 mg OD and tablet spironolactone and tablet amiodarone 200 mg BD. In the family history, there was no known case of hypertension and diabetes in the family. No known case of coronary heart disease in the family. In the general physical examination, he was conscious, cooperative, well-oriented to time, place, and person, moderately built and nourished. His height was 165 centimeters, weight was 67 kgs. His BMI was 24.6, breath holding time was 36 seconds, effort tolerance was decreased. It was 1 to 2 flight of stairs. His MET score was less than 3. He had purple discoloration of the lips and the cheeks, which was suggestive of the mitral phases. His vitals was, in his vital examination, pulse was 78 per minute, irregularly irregular, low volume, no radial or radiofemoral delay. Apex pulse deficit was 10 beats per minute. BP was 128/76. On room air, he maintained a saturation of 100%. JVP was raised 8 centimeters above the angle of fluid. Respiratory rate was 18 per minute, abdominal thoracic type of respiration. In the general physical examination, he had pedal edema of pitting type, no pallor, no icterus or clubbing, no generalized lymphadenopathy, no alopecia, no spider neva. Modern silence test was of grade 1. In the airway examination, mouth opening was 3 fingers. He had buck teeth. MPC was 2. Modified Malampatti classification was 2. Thyromental distance was more than 6.5 centimeters. Neck movements were adequate. There was adequate flexion and extension. Upper lip bite test was class 1. In the systemic examination, firstly in the cardiovascular system, on inspection, apical impulse was seen in 5th intercostal space with no other palpable pulsation seen or no scars. Precordium was normal. In palpation, apical impulse was in 5th intercostal space, tapping in nature, 0.5 centimeter medial to the midclavicular line. Left parasternal heave was present of grade 2. Diastolic shock was present and carotids were normal. On auscultation, S1 was loud on auscultation and S2 was normal. Opening snap was present. Rough mid-diastolic murmur, low pitched, non-radiating, best heard in left lateral position with breath held in respiration. It was best heard with a bell of the stethoscope, which increased with exercise and decreased with the rest. In the other systemic examination, respiratory system, bilateral air entry was equal and clear. Normal vesicular breath sounds were heard in all areas. In central nervous system, higher mental functions were normal. No focal neurological deficits were seen. All cranial nerve examination was normal. On per abdomen examination, liver and spleen examination were normal. Flanks were free. No visible mass or scar was seen. My provisional diagnosis based on the history is a 36-year-old male with moderate mitral stenosis with atrial fibrillation, NYHA class 2 with pulmonary arterial hypertension suggestive of rheumatic heart disease.
On the basis of your provisional diagnosis, what you want to do, what investigation you want to do in this case?
Ma'am, firstly, I would like to do all the routine investigations. Firstly, CBC, serum creatinine and serum electrolytes. Along with that, I would like to get a ECG done, chest X-ray done, and a 2D echo done because it's a cardiovascular case, ma'am.
Why you want to do these investigations?
Ma'am, I would like to do a CBC because in case of mitral stenosis, person there is a chance of malnourishment, and I would like to know before posting to the surgery his hemoglobin count, ma'am. There can also be electrolyte imbalance, and because of decreased cardiac output, the patient can also have renal complications. That is why I would like to get a renal function test done and a liver function test done because he also has a history of alcohol consumption, ma'am. And for knowing the electrolyte imbalance for the management of the case, I would like to know the electrolytes.
Rajesh and Vaishali, you want to ask any question on the history?
Yeah, Dr. Amit, good evening. I'm Dr. Rajesh ARYA. And first of all, I greet my two teachers, Dr. Jashi Sood Madam and MANJULA Madam. And they have been great teachers. So not wasting much time, may I ask you, why did you do the angiography in this patient?
So he presented with breathlessness and palpitations. After
So once
2D
you
echo
got a, sorry, yeah.
So his angiography was done after the 2D echo was suggestive of rheumatic heart disease. Then the angiography was done.
So once you get a patient of rheumatic heart disease, to be more specific of mitral stenosis on echocardiography, in a patient of 36 years,
Amit, you can unshare your screen so you will be visible for the monitors.
No, let the screen be there. Let the screen be there.
Okay.
I just want to see the diagnosis and other things. So at the age of 36 years, what are the indications for angiography? Any guidelines? Or it's a routine institute policy?
Coronary angiography, before he was posted for surgery, coronary angiography was done to know any other blockage of the coronary artery diseases. If the person has
at the age of 36 years, and to be more
Yes.
specific, in the patient of mitral stenosis, what are the indications? What are the guidelines says? For people less than 40 years, it is not recommended. If somebody is more than 40 years, you may do angiography, provided there are other signs symptoms are there. So probably
Yes.
the role of angiography is very limited in such patient. Why this patient was on Codron? Why not any other drug?
So he had the person was in atrial fibrillation, and it was a rate controlled one. So that is why the patient was put on oral cardrons.
So, but oral Codron is a drug of choice, or beta blocker is a drug of choice?
So
Why
beta blocker,
specifically on Codron?
so beta blocker or calcium channel blockers are the drug of choice, sir.
The calcium channel blocker is not a drug of choice.
Beta blockers are the drug of choice, sir.
Then why specifically he was on Codron? Any reason? Did you inquire with the cardiologist what was the reason of putting him on Codron? Because these patients, they have what you said, patient had moderate pulmonary hypertension, which means the right side signs of right side failure are expected in this patient. Okay.
Yes.
With the presence of those, and if you give Codron, it is going to affect the liver system furthermore.
Yes.
So Codron is not a drug of choice in such patients.
Yes.
So I don't find any reason to start Codron in those. And you said the patient had moderate pulmonary hypertension, and echo you have not yet disclosed, no? I think so.
No, sir. I have not
Okay.
mentioned the investigations.
Okay, let other panelists may ask questions, please.
Vaishali, you have to unmute yourself.
Which is the most common cause of mitral stenosis? Can you tell me, Amit?
Ma'am, rheumatic fever is the most common cause of the mitral stenosis in India, ma'am.
Okay. In your was there any kind of signs and symptoms of rheumatic fever in your patient?
Ma'am, he doesn't give any history of history of polyarthralgia or fleeting type of joint pains. No history of even in childhood, ma'am. He doesn't give any history of rheumatic fever.
Okay. Can you enumerate John's criteria?
Ma'am, Jones criteria can be major and minor criteria, ma'am. Presence of carditis, arthritis, subcutaneous nodules, chorea, and erythema marginatum are the major criteria, ma'am. And
What are the Indians which you will get in Indian population?
in Indian population, we'll be seeing carditis, arthritis, subcutaneous nodules, and chorea, ma'am. Erythema marginatum is not commonly seen in the Indians.
Okay. Minor
Yes.
criteria?
Minor criteria, clinical fever and arthralgia can be seen in the Indians.
Okay. And how when you will diagnose it as a rheumatic origin mitral stenosis?
Ma'am, for the conclusion of the diagnosis, I'll be getting the titers done, ma'am. The lab investigation is done for the evidence of the streptococcal infection. The increased titers more than 250, then a positive throat culture, and there might be a history of a recent scarlet fever, ma'am. Along with that, two or one major criteria and two minor criteria, ma'am.
Okay. And how the rheumatic fever is treated?
Ma'am, rheumatic fever is treated with a penicillin.
Nowadays, do they use penicillin?
No, ma'am.
So what is the new ARYA? Have
What
you
is
asked
the-
any history? Have you asked any history of penicillin 21 days or something like that? Have you asked?
Yes, ma'am. I had asked him, ma'am, but he didn't have
He
a
never
complaints
gave
of fever itself.
Okay, okay. So can you tell me a little bit about the pathophysiology of mitral stenosis? Why do they present at the age of, why he should present at the age of 36 years?
Ma'am, in case of mitral stenosis,
How it
the
progresses?
ma'am, post streptococcal infection, ma'am, there is a cross reaction. There is a generation of the antibodies, and that leads to the cross reaction. That leads to the fibrosis of the chordae tendineae, which leads to
What
the
happens? What happens to the leaflets?
ma'am, the leaflets are mitral stenosis is a bicuspid wall, ma'am. There is thickening of the leaflets, ma'am. And also the chordae tendineae. There can also be a fusion of the commissures, ma'am. Which can lead to the fishmouth appearance of the leaflets. This leads to the restriction of the leaflet motion, and mainly the anterior mitral leaflet. That leads to the mitral stenosis.
So what happens to the blood flow?
Ma'am, because of the decreased motion of the leaflets, there is a decreased diastolic filling, and there is
Diastolic
also
filling of
decreased diastolic filling of the left ventricle.
So
Uh,
then
that that increases the pressure gradient in the atria, left atria. That leads to the back pressure. Because of the increase of the back pressure, there is a pulmonary edema, and that leads to pulmonary artery hypertension.
Okay. So what is the cause of pulmonary hypertension in your case? Is it a long-standing mitral stenosis?
Yes, ma'am. Long-standing mitral stenosis.
Okay. How did you get it clinically? What sign
Ma'am,
was present?
Ma'am, clinically, because of the long-standing pulmonary hypertension, the patient had also developed the right-sided right ventricular hypertrophy. Because of right ventricular hypertrophy, he had a parasternal heave of grade 2 present, and also palpable P2 present, ma'am, diastolic shock.
And
He also had a bilateral pitting edema, ma'am.
okay. And as sir said, what other signs were of right ventricular?
He complained of breathlessness and his main complaints, ma'am, breathlessness and palpitation.
Okay.
How can you say on history this is moderate PH?
So, based on the history, sir. Sir,
So
he's
you said something about the P2 loud P2, na?
yes, ma'am.
So is it suggestive of pulmonary hypertension?
Yes, ma'am. Yes, sir. The loud P2 is suggestive of pulmonary hypertension.
No, how do you grade pulmonary hypertension based on clinical findings? You said moderate. You can simply say is the pulmonary hypertension present.
Yes.
Moderate pulmonary hypertension, how can you grade on clinical history?
So he is asking grading of pulmonary hypertension clinically. How you are going to grade?
So a suggestion to you, I mean, don't confuse yourself and don't get yourself trapped in the examiner's questions. Simply write on clinically there are signs of pulmonary hypertension. Finish.
Yes.
That's all.
Yes. Yes.
No
Yes.
need to write moderate.
Yes.
Okay. How will you classify mitral stenosis? Severity of mitral stenosis?
Ma'am, mitral stenosis can be classified mild, moderate, and severe, ma'am. For this classification, we'll be taking three factors. One is mean pressure, decrease in the mean pressure, then pressure half time, and then mitral valve area, ma'am. In the usually we consider mitral valve area, ma'am. In mild, the mitral valve area is 1.6 to 2 centimeters square. In moderate, it is 1.5 to 1 centimeter square. If it is less than 1 centimeter square, we consider as a severe, ma'am. The normal valve area is 4 to 6 centimeters square.
Does it
Other than
changes
that,
your management of anesthesia? Mitral
yes,
valve area?
yes, ma'am.
How? Why you want to grade? Why you want to grade the severity of mitral stenosis?
Ma'am, in case of severe mitral stenosis, it will be like a fixed cardiac output.
Yes.
Yes, ma'am.
And chronically
So,
depleted LV function.
yes, ma'am.
And
So I would like to, and in such cases, I would like to avoid volume overload and tachycardia.
yes. Okay.
I think let's go further about it because we have got one more case.
Yes. Investigations?
Investigations. His hemoglobin level was hemoglobin was 17. Total counts were 9,300. Platelets were 2,13,000.
Just
Sugar.
enumerate the positive
17?
findings. I mean,
Hemoglobin 17?
Yes, ma'am.
just keep on moving on to the positive findings. No need to write the normal, speak the normal things, please. Save time.
Yes. Yes. So on ECG, he had a rate controlled atrial fibrillation, and on 2D echo, sir, the ejection fraction was 55%.
No.
It was
What do you mean by rate controlled atrial fibrillation?
so Sorry, sir. ECG showed atrial fibrillation.
Atrial fibrillation with controlled ventricular rate.
Yes.
That's a better
Controlled
way of
ventricular
saying
rate.
it.
Yes, yes. Controlled ventricular rate. Yes. And 2D echo showed moderate mitral stenosis, trivial mitral regurgitation, and trivial tricuspid regurgitation, sir. And mitral valve peak pressure gradient was 17, and calculated mitral valve area was 1.2 centimeter square, and mean pressure gradient was 9, sir.
Just hold on at this moment, because this is the main slide where your exam will go. Okay, once you reach the management, it means you have passed the exam. And to reach the management, first thing, this is the only thing you look for ECG in a patient with mitral stenosis?
In 2D echo, sir.
No, on ECG I'm asking. What more things you see, look into the patient with mitral stenosis? Starting
So
from the P
people-
wave.
What
What
are
do
the
you
other
expect in the P
findings
wave?
you will get it? What are
What
the
do you
other
expect in the
findings?
So P pulmonale.
P pulmonale, what does it mean?
P pulmonale is suggestive of the clefting of the P wave is suggestive of left atrial enlargement, sir.
That is P
Sorry,
mitral
sir.
or P pulmonale?
Sorry, sir. P mitral is suggestive of left atrial enlargement. P pulmonale is suggestive of pulmonary hypertension or right ventricular hypertrophy.
What is the cause of P mitral? What shape of the wave you get in P wave, and why does it happen?
So in P mitral there will be cleft in the P wave, sir. In P
Why is the
mitral, sir.
cleft? Why is the cleft?
Because of the left atrial enlargement.
So what happens in the left atrial enlargement? May I answer you? I mean, just to save time. Normally, the P wave which starts from the SA node traverses through both the atria and reaches the AV node. Okay. In a normal situation, the P wave passing from the right atrium, the left atrium, they are at the same time superimposed, and you get single P wave. But in mitral stenosis, the left atrium is enlarged. So the left atrial side wave takes more time to reach the AV node. So first the right atrial wave reaches, and then comes the left atrial wave. So it becomes one after another. So they are split into two. That comes a P mitral. Okay. Apart from that, what about the QRS complex? What about the rhythm, and what about the progression of QRS complex on the ECG?
So apart from the P wave, sir, there will be prolongation of the QRS complex.
Why so?
Because of the right ventricular hypertrophy.
No. When in the presence of atrial fibrillation, you said we cannot comment on the PR interval,
Yes.
because patient is in atrial fibrillation.
Atrial fibrillation.
So what is
yes,
atrial fibrillation? How do you diagnose atrial fibrillation? That's again a big topic. But the rate more than 180 with the absence of P wave will give you the diagnosis of atrial fibrillation. So you said
Yes.
about the QRS complex. There will be poor progression of the QRS complex R wave because of the right ventricular hypertrophy, and the rate you said is controlled. Coming to the X-ray, what are the 14 findings in the patient of mitral stenosis in X-ray?
So
This is what Dr. R.D. Patil used to ask us. Give me the numerical 1, 2, 3, 4, 14 findings in the patient of mitral stenosis.
So on chest X-rays,
Yes.
there can be, because of the pulmonary edema, there will be pulmonary congestion can be seen.
Patient may have
So
pulmonary
then-
edema, may not have pulmonary edema. Pulmonary hypertension you say instead of pulmonary edema, you say pulmonary hypertension.
Yes. So and yes, there will be straightening of the left heart borders.
Okay, good.
Then hockey stick appearance.
Hockey stick appearance on X-ray.
No, sir. There will be straightening of the left heart borders.
Right. Number 2. Carle ABC lines because of pulmonary hypertension.
Yes.
Subedar
Yes.
mustache sign.
Yes.
Narrowing of the area of trachea. Signs of hemosiderosis. Signs of calcification in the lung tissues. Sign of calcification of the mitral wall area in the cardiac tissues, cardiac shadow. Pleural effusion. Pulmonary plethora. This is what I remember out of 14 points RD used to ask, at least 6, 7, 8 I remember still. Okay. So this is what you are expected to know as a student appearing for MD exam.
Yes.
Going for the diagnosis is very easy. I mean, nowadays nobody uses stethoscope, and you can just simply put a echo probe and get the diagnosis. Or it's already made when the patient comes to the anesthetist. But if you know yourself what you see in the X-ray, probably if you find pleural effusion, you can tell, okay, put a bilateral chest tubes. So this is important for anesthetists to know the basics of it. Okay, now carry on next to that. Echo. This is what the echo report you expect. Or what
Sir,
else you will see in the echo report?
Sir, the decrease in the ejection fraction, left ventricular ejection fraction, sir.
No, no. Mitral stenosis patients mostly have normal ejection fraction. Most of the time they'll have normal ejection fraction, normal LV size. A rather smaller LV size with good ejection fraction. That is most common in the pure mitral stenosis. In the later stage of combined mitral MS-MR, they may have low EF, but otherwise per se they normally have.
So decrease in the in 2D echo, I'll be expecting the decrease in the diastolic motion, sir. Then
Diastolic motion?
Something about the valve.
Wall. How does the wall look like first?
the thickened the wall looks the hockey-stick appearance of the wall can be seen, sir. The wall will be thickened and immobile. The thickened and immobile cusp, sir. Then reduced
Some
wall
better word
area.
for that? Restricted movement of the leaflet.
Yes.
Restricted movement of the base and the body of the leaflet, only the tip moves. In the history, you said most of the time it's the anterior mitral leaflet is involved. That is not correct. It's the any of the leaflet can be involved, and most of the time what we see is the posterior mitral leaflet retraction. Okay, tethering of the PML. That is the exact word used for mitral stenosis, because it gets stuck to the, I mean, all the chordate tendon and all becomes stiff. And to brief you, I mean, this mitral stenosis is not a disease of mitral wall itself. It's a mitral wall apparatus which is diseased. The wall, the annulus, the subvalvular apparatus, or even the LV wall may have fibrosis because of rheumatic disease. Okay. So one you said is the hockey stick appearance of the mitral wall. Fine. Number two.
So there will be flattening of the EF curve on 2D echoes.
Flattening of
EF curve on the EF curve on the 2D echoes.
EF curve.
Yes.
I don't understand what is this EF curve.
In the planimetry, the EF curve is flattened.
So I think you're confusing yourself for us. Okay. What happens to the left atrial size, shape, and anything special you look for the left atrium, which is going to change your management? I'm asking the things which you have not written, which are important.
What happens to the size of the left atrium? Dilatation, na? So size will increase.
When there is stenosis to the forward flow, the backward pressure and the volume will increase. So there is
left
increase in the
atrial,
size.
yes.
What will
Yes.
happen to the flow? The flow is reduced because opening is less.
Reduced.
So whenever there is flow is reduced, there is stagnation of blood. And whenever there is stagnation of blood, what happens? Clot formation, thrombus formation, clot formation. So would you look out for the thrombus and clot in the left atrium?
Yes, yes.
And if in left atrium or any specific place you will look for it?
LA appendage, you have to look for the clot.
Yes.
LA appendage, because that is going to change the
LA
entire management. A patient with mitral stenosis comes with a pregnancy, and you decide whether it's a open mitral valvotomy or closed mitral valvotomy or MVR or mitral dilation, whatever it is. So that will change your entire management. Okay. Then what else you look for an echo? You look for the right side structures also. You look for pulmonary regurgitation. You look for the right side hypertrophy and volume of the right ventricle. You look for the tricuspid wall regurgitation, because it's a back pressure changes. From the mitral wall, if the back pressure keeps on increasing, it will hit the tricuspid wall. First the pulmonary wall, Many a times they have got PR, and after PR, it will hit the tricuspid wall. That's the reason you said pedal edema and the right side failure. It means patient has got right ventricular hypertrophy and tricuspid regurgitation. Till the TR is not there, the pulmonary edema and the right side failure won't be there. Okay, so you have to think retrospectively how the pathophysiology is working. Then only you can make what category of this risk this patient has and how I'm going to manage this patient, depending on the risk. You won't give volume, you won't give drugs which are hepatotoxic, you won't give, I mean, so many things you can decide on your anesthesia part once you know the pathophysiology of the disease. Next. Carry on next, please.
Next, after investigation, what you will do now? 2D echo is over.
Yes. Then
Anything else? Anything else you want to do?
Or this is all you want to say? Then we can spend 5 more minutes with you. If there is no further slide, we'll just
So what
conclude.
optimization you want to do in this case now?
Yes, sir, I would like to put the patient on a beta blocker, sir, for the rate controls.
So a
Then
beta
I'd like
blocker. Then what else?
Then nebulization for the patient, ma'am. Pre-operatively,
Nebulization with what?
so there can be pulmonary congestion to reduce the pulmonary congestions.
Would
No,
you
no,
like to
with
give
what drug?
diuretics? Would you
With-
like to
with
give
what?
diuretics to this
Yes,
patient?
ma'am. Yes, ma'am. Yes, ma'am. I would like to give diuretics for the patient.
No, nebulization with which drug you will do?
So nebulization with nebulization can be given with normal saline.
Normal saline. What for? What? How the nebulization normal saline will help in this patient? Why do you want to give it? See, by simply saying we'll nebulize the patient, so bronchodilation purpose or better ventilation doesn't solve the purpose. If you nebulize him with ethylene, that is going to harm him.
Yes.
If you nebulize with the steroids, that will help him. So you have to be
Yes.
specific what you're going to do.
Nebulization with budesonide.
Nebulization with?
Budesonide.
Okay.
Will you do regular nebulization to such kind of the patients when you are doing this case in CVT COT?
No.
Okay, fine. What else you want to do?
Then I would also like to put him on diuretics, ma'am, and anxiolytics a day before surgery.
Okay, what are the options for this patient for surgery or any other option?
Apart from surgery,
Treatment
ma'am,
options.
BMV, BMV can be done, but not for this patient.
Why?
Why not?
Why?
Ma'am, for BMV, there should not be one thing we will looking in the would be the movement of the leaflet, the good movement of the leaflet and the calcification of the
No.
calcification.
There are certain criteria, Wilson's criteria for selecting a patient.
Yes, sir.
So,
Wilkins
so
criteria.
your answer
If
should be
Wilkins criteria
for
is less than
BMV,
8.
if this patient we plan for BMV, we have to rule out any clot or thrombus in the left atrium or left atrial appendage. And after that, if that is not there, we'll go for the Wilson scoring. If the scoring is this much, we'll go for BMV. Otherwise, we'll go for any other procedure. This should be the
Yes,
answer,
sir.
to be precise. So
Yes,
that you don't
in
catch up with speaking wrong and then examiner pulling you further on that.
Yes. For Wilkins criteria, we'll be checking leaf mobility, valve thickness, and subvalvular thickening, sir. If it is less than 8,
Okay,
and
now
if
just
there is no
Sri, we have got another speaker also, if Madam permits me. Before I go for to the next speaker, last few quick questions. This patient comes for some fracture humerus or where you have to use general anesthesia. What is the drug of choice as a muscle relaxant?
So I would like to use vecuronium, sir.
Reason?
So vacuronium is cardiostable. There is no histamine release as seen
Why
with the
not
atracurium,
rocuronium?
and
Why not rocuronium?
so tachycardia is also no, rocuronium and pancuronium are vagolytic. They can cause
Rocuronium is the most
tachycardia.
cardiostable, I would say. Okay. Then anti-CLL you will give which one and why?
So I would like to prefer glycopyrrolates.
And induction agent?
Induction agent etomidate.
Will you use the same size tube as indicated or a smaller size tube, and reason why?
So the smaller size tube because they can, because of the dilatation, there can be compression over the trach.
No. Because of pulmonary hypertension, there may be mucosal edema. So you have to use a slightly smaller size tube, a 0.5 number lower, or you should keep less pressure in the cuff. What drugs you will use to just before intubation, and what is the reason of doing that? What is your aim in the intubation basically about the pressure response?
So during induction, sir, I would like to do opioid induction, sir, because to prevent
Next.
tachycardia and hypertension.
That reason if we have a doubt that you don't know, we'll ask. Otherwise, we presume that you know. Opioid induction, correct?
Yes.
Anything more? What is your aim about the heart rate?
Sir, to prevent tachycardia.
So what you will do? What will you use as a precaution or as a preemptive measure to avoid tachycardia during intubation?
Beta blockers.
Beta blocker. Anything else? These patients are on a borderline blood pressure, say 90, 100 pressure. Will you use beta blocker in those? Fixed cardiac output state, will you use beta blockers? Xylocard, magnesium, local xylocaine spray, the cuff of the tube lubricated with xylocaine, clonidine.
What you do in operation theater, tell that now. You did the mitral stenosis case, na? So what did you do?
Sir, I'll prefer to use xylocards and local sprays and application of the jelly over the tube and try to see the attenuate the intubation response.
Yes, so these all are important things, because if this patient has got a heart rate of your patient is luckily a 76 heart rate. If the patient has got 96 heart rate, you intubate, the heart rate goes to 140, the pressure comes to 50. And then you are in a mix-up. You start adrenaline, noradrenaline, the pressure doesn't come up. The reason was the heart rate. In that situation, the pressure is 60, you have to control the rate. So these are important things, Amit. I think you need to prepare a little more, with the depth of the subject, and don't just focus on the disease itself or a particular part of it. You have to come out of your tubular vision. I'm sorry to say that. But this is your budding age. I think we should advise you. Am I right, ma'am?
Yes.
Yes, yes.
Yes.
We can give 10 more minutes to him because this is a long case. And Vaishali, you want to ask something?
And ideally, you should avoid tachycardia and hypovolemia at the same time. You should maintain the heart rate. So for that, you have to see whatever drugs you are using should be off additive, because most of the drugs have whatever you are using are cardiostable. So patient should not go below 60 also and should not go above 80 also. So your maintenance of heart rate should be 60 to 80. For that, you should plan your anesthesia. Okay. That is how we are doing all the investigations, and we are planning our anesthesia. What type of monitoring would you like to do in this case?
Ma'am, intraoperatively, ma'am. Firstly, I'll be doing ECG monitoring, starting with the saturation monitoring, ECG monitoring, then ATCO2 monitoring.
Whenever you are telling your examiner, always start from first A of your monitoring parameter of your multi-para monitor. It is always ECG. Okay, ECG
Yes.
heart rate. Okay, so
Yes.
you should say heart rate and ECG, then come down.
Yes.
Okay, so you will not miss anything.
Yes. Heart rate and ECG monitoring, then saturation monitoring, then ETCO2 monitoring, temperature monitoring. Then I would like to put a arterial line for B2B to monitoring, blood pressure monitoring. Then along with that, arterial blood gas monitoring, serum electrolytes, urine output.
You have put arterial line. Any other line would you, invasive line would you like to put?
Along with the arterial line, I'll also put a central line for a CVP monitoring. Then CVP monitoring, then arterial blood gas, serum electrolytes, urine output. Then I'd also like to do a transesophageal echocardiography and cardiac output monitoring.
Anything else? One more thing you are missing. If you are putting a patient on bypass.
Sugars monitoring.
Anything else?
Coagulation.
Heparin, when we give heparin, what we do?
Ma'am, activated clotting time.
Yes.
Activated clotting.
Okay. You have to monitor activated clotting time. How much heparin will be given?
Ma'am, 300 units per kg body
And
weight.
how much ACT will you maintain?
ACT more than 400.
Okay. And I will not ask you anything about this bypass, but you must read all the things. Okay.
Yes.
Basic principles of bypass.
Ma'am, the cannulation of the aorta is done, and the cannulation of the inferior vena.
Not basic principles means it is based on which principle? Patient will be heparinized. Patient will be hemodiluted. Okay.
Yes.
And patient will be given some amount of hypothermia. Not very nowadays they are not doing because, but some amount of hypothermia. So it will change your body chemistry, and accordingly you have to monitor on bypass also. Okay.
Yes. Yes.
Okay. Post-operative monitoring, post-operative precautions.
Ma'am, post-operatively, I'll check for the blood pressure monitoring post-operatively. ECG and heart rate monitoring. I'll maintain urine output monitoring, then arterial blood gas monitoring, then electrolytes imbalancement, then post-operative sugar monitoring, then prevent pain because pain can lead to tachycardia.
What we check in the drain, what we check in the drain? Is there any chances of bleeding in the post-operative period immediately shifting?
Yes, ma'am. And post-operative check for the bleeding. I have checked for the adequate reversal with the proton. So post-operatively check for the bleeding.
In so many things you need to blood transfusion therapy and all those things you need to read all the things, like blood products and blood transfusion therapy when it should be given and all those things you must read. Okay.
Yes,
What things you should check while coming off bypass, how to shift these patients, all these things you have to read. Okay.
Yes.
You have you should see the temperature monitoring is very important, because post-operatively if the patient is hypothermic, then what will happen? What will happen if your patient remain hypothermic? They generally rewarm the patient, then we come out of bypass, and then again the temperature goes down. Okay. There is a drift of temperature, so it will affect your coagulation. Okay. So you should always see your patient is on a normal temperature. Okay. While shifting, proper care of temperature monitoring and all those things should be taken. Okay. Warming and all those warming blankets and all those things should be taken while shifting. Otherwise your patient will bleed. Anticoagulant with effect will be pronounced in the hypothermic conditions. Okay.
Amit, you can unscreen your share, unshare your screen, please.
Yes.
Last question from my side to you. If the mitral stenosis case comes to you for cesarean section during emergency, what will be your choice of anesthesia for that time?
Ma'am, my choice of anesthesia would be I would like to do a 2D echo and do the grading, mild, moderate, and severe. If it is mild and moderate, we can. My choice of anesthesia would be epidural anesthesia, and I'll check for the coagulation profile. My choice of anesthesia would be epidural anesthesia. If it is a severe type of mitral stenosis, my choice of anesthesia would be general anesthesia.
So if it is severe and patient is in failure, would you like to ask the cardiologist to do the BMB and then take for
Yes,
cesarean, or cesarean will be
Yes,
done first?
I'll request the cardiologist to do the BME first, and then I'll take for the cesarean section.
And if the fetal distress is there, then?
If it is a emergency, then we'll do mitral valvulotomy and take for the cesarean section.
But if your center is having that facility, you will go ahead, na? If the center doesn't have that facility, what you will do? Will
Mitral
you not go
valvulotomy.
for cesarean section? Patient
Yes,
is in fetal distress.
Yes, ma'am.
It could have been a precious pregnancy also.
Yes, ma'am.
What is the main problem with this severe mitral stenosis? Once the baby is out,
She's going to.
There will be overloading, no? Auto transfusion. So what happens?
Yes, ma'am. Because of auto transfusion, there will be pulmonary edema, and she might go into failure.
So you have to be ready for that.
Yes.
I think we can stop here and ask for the second person. Rajesh,
Amit,
Vaishali.
Amit, you are in which year? Second year, final year, or
Final third year.
third year? So for third year, it is good that you have presented well, but little bit of more wider aspects of this. But otherwise, the presentation was very good.
Yes. Thank you. Thank you. Thank you.
good. Read well. Okay.
Thank
All
you.
the best.
Thank you.
So now we invite the second speaker, second presenter, Dr. Aditi.
Good evening, ma'am. Good evening, sir.
Good evening.
Ma'am, can you see my screen, ma'am?
Yes, we can.
Good evening, sir and ma'am, and all the esteemed faculty who joined us for this webinar. I'm Dr. Aditi Vade from D.Y. Patil Hospital, and my moderator is Dr. MANJULA SARKAR, ma'am. My topic for this discussion today is the case of an atrial septal defect. I would like to start my presentation, ma'am, sir. This case is of a 4-year-old girl child who presented to us and the informant for this case was her mother, a reliable source. She came with the complaints of recurrent cough with expectoration since 6 months of age. There had been multiple episodes of recurrent cough and expectoration and was treated with antibiotics for the same repeatedly. She also had fatigue. The child walked out of unconscious managed. There was no intrauterine exposure to teratogenic drugs, ionizing agents, or infection. Normal vaginal delivery was there, and the birth weight was 3.2 kg. All the developmental milestones till the age were achieved, and she was vaccinated till date. On general examination, patient was comfortable at rest, height of 101 centimeters, weight 15 kgs, BMI of 15.2 kg per meter square, which is appropriate for her age.
Aditi,
She had a pulse rate of 110 beats.
Aditi, can you come to the, just read
Yes,
out the
sir.
positive findings. That will be much easier and save time, and we can spend more time on discussion.
Yes, sir. So on general examining all things within non-limits, and since she had complaint of recurrent cough with expectoration, we also ruled out the possibility of a cleft lip or a cleft palate case. No other congenital anomalies on general examination was seen. No features of congestive cardiac failure or infective endocarditis were also ruled out. So we proceeded to a cardiovascular examination, which showed pericardium to be normal. The apex beat in the fourth intercostal space shifted to the left. S1, S2 was present with a wide fixed split S2 sound and an ejection systolic murmur in the area of it.
Your voice is breaking.
Yeah, on the basis of history and examination, what is your diagnosis?
Ma'am, on the basis of physical examination, we diagnosed the cardiovascular disorder of the patient with a pretty
You are not audible.
Can you hear me now?
Your voice is breaking.
Ma'am, can you hear me now?
No.
Ma'am, am I audible now, ma'am?
Yes, now we can hear you.
Ma'am, on the basis of my history and examination, we diagnosed a cardiovascular a probable diagnosis of a cardiovascular disorder was made, and in that a atrial septal defect diagnosis was made.
So Rajesh and Vaishali, you can start the discussion, please.
So how will you go ahead with the investigation now?
Ma'am, what
You
suggests
ma'am,
like
your
patient had
diagnosis,
ASD
no?
on clinical examination?
Sir, with the history of recurrent cough and expectoration and on auscultation, a wide fixed split S2 sound with an ejection systolic murmur in the pulmonary area. Also, the apex beat was shifted towards the left in the fourth intercostal space.
Ejection
And rest
systolic
other
murmur because of?
in the pulmonary area, sir, because of in ASD there would be volume overload to on the right atrium, right ventricle, and further in the pulmonary valve. So because of that, there will be a murmur sound of the blood over the pulmonary valve, and therefore an ejection systolic murmur would be heard.
That can happen in any left to right shunt. How do you reach the diagnosis
Yeah.
of ASD?
Sir, yes, sir. In any left to right shunt can be there. And there was a wide fixed split S2 also present. No other features of dyspnea on exertion or
No, but how do
sinuses
you
or
say? You should say that patient had some probably cardiovascular involvement with left to right shunting.
yes,
Reaching
a
directly to
cardiovascular
ASD is,
disorder with a
on
left.
clinical is a little harsh to understand.
Yes, sir. A disorder with a left to right shunt in a probable diagnosis was diagnosed.
Okay, next what?
So for investigations, then we would like to ask for a CBC profile, a renal function test, blood grouping, coagulation profile. After that, an ECG, a chest X-ray, and 2D echo in order would be advised for the patient, sir.
On X-ray, what do you find in a patient of ASD?
So on X-ray, since there is increase in the for a case of ASD, since there is increase in the pulmonary blood flow, there will be increased pulmonary markings of pulmonary plethora may be seen. The right atrium and the right ventricle are enlarged with pores. Therefore, increased right atrium, right ventricle border could be seen. On chest X-ray, these findings could be found, sir. And in prominent pulmonary markings. Pulmonary veins, prominent markings in the area of the pulmonary veins could be seen.
Okay. Then on ECG, what we expect?
So in ECG, sir, findings will be seen. Yes, significant findings on an ECG are seen if the flow ratio, if the pulmonary resistance to the systemic resistance is more than 1.5:1. In those cases, right axis deviation, a right bundle branch block can be seen. RSR pattern in lead V1 could also be seen, sir, in an ECG.
So ECG, you will see the changes of right ventricular hypertrophy,
Right ventricular hypertrophy, yes.
right atrial hypertrophy, P
Right
pulmonary,
atrial hypertrophy.
P pulmonary.
Yeah, yes. Hmm. And an RSR pattern because of increase in the blood flow over the
That is the sign
infant.
of RVH, no? We said already. Okay, next what?
Sir, after these, 2D echo would be a gold standard test for if we are suspecting a in any left to right shunt to further diagnose, and a 2D echo would be considered as the investigation of choice. On a 2D echo, we can see the it can help us to diagnose the position and the size of the defect of an atrial septal defect.
Just the size of the type also.
Sir, type can also be seen depending on where the atrial septal defect is present. On some levels, you can also see the type of the atrial septal defect on a transthoracic echocardiogram. But if the findings on that are crude and we are not able to come to a final diagnosis, we can also do a TEE, transesophageal echocardiogram.
Okay, just
Which can
finish
give
your
us a better
presentation, then we'll
understanding.
ask questions, please. Unless Dr. Other ma'am want to ask something.
Can you enumerate the types of ASDs, or classified?
Yes, ma'am. Yes, ma'am. ASDs can be classified as ostium, depending on the place where they present as ostium primum atrial septal defect, ostium secundum atrial septal defect, sinus venosus atrial septal defect, and a coronary sinus atrial septal defect.
Okay. Is it associated with any other cardiac anomaly? Sinus
Yes,
venosus
ma'am.
or something?
Yes, ma'am. Usually, a ostium primum defect is associated with other congenital anomalies, like it can be present with a ventricular septal defect. Sinus venosus ostium, a sinus venosus atrial septal defect can be of two types, depending on the place where it is present. If it is associated with the superior vena cava, there can be a communication of the superior vena cava with the upper right pulmonary veins. With the inferior vena cava, if it's associated, then the inferior vena cava with the lower pulmonary veins.
Okay. Can you enumerate classification of congenital heart disease?
Yes, ma'am. Ma'am, congenital heart diseases can be cyanotic and acyanotic congenital heart diseases. More common acyanotic congenital heart diseases are more common than cyanotic congenital heart diseases. In acyanotic congenital heart diseases, we can classify them as an obstructive stricture congenital heart diseases, obstructive congenital heart diseases. In stricture congenital heart diseases, we can have atrial septal defects, ventricular septal defects, coarctation of aorta, and in on obstructive lesions, we can have atrial stenosis, pulmonary stenosis, coarctation of aorta, Epstein's anomaly. Cyanotic congenital heart diseases, example of them are tetralogy of Fallot, tricuspid atresia, transposition of greater arteries.
So if suppose it is the patient is associated another congenital heart disease, would you like to do any other investigation along with after echocardiography? Which other investigation is subjected? Patient is subjected.
CT and MRI are also being used as the
Yes.
further investigations to diagnose other conditions.
Yes. Okay. So that is one of
Yes,
the
ma'am.
way of evaluation of congenital heart disease, because it can be associated with other anomalies. Okay. Any
What is
other
the-
anomalies? Okay, sir.
What is the incidence of ASD in general population?
Sir, about 10 cases in 1,000 live births. 1 to 10 cases in 1,000 live birth.
1 to 10 is a
can
very
be there.
wide range you are telling. In 1,000, 1 to 10.
Yeah.
It may be this
Sir,
becomes 0.1 to 1%, which is very low.
okay.
The incidence is very high. What is the lifespan
So
of a patient?
usually they go asymptomatic.
What is the life,
Yes, sir.
the progress of the disease as per the decades of life of ASD?
Sir, usually an atrial septal defect goes undiagnosed, or it's a symptomatic case present in the developed countries, or with the establishment of the investigations that we have. These cases present by third to fourth decade of life, and survival rate till third to fourth decade is for a smaller atrial septal defect is good. So till third to fourth decade, the cases can present to us, sir.
What are the compensatory mechanisms of body in a patient with ASD as far as the pulmonary circulation is concerned?
Sir, there is in ASD, there's a shunt from the left to the right side of the heart. So the pulmonary blood flow increases from left to right side. Over time, the there is right atrial and right ventricular enlargement, and the blood flow over the pulmonary veins also increases. So over time, the muscle layer starts developing, and with this increased muscle layer, increased musculature of the vessels, pulmonary hypertension develops. So this compensation, this is a compensatory change that occurs, sir, over time.
What is the course of the right ventricular morphology in patient with ASD over a period of time?
Sir, with the increase in blood flow from left to right shunt, right atrium to right ventricle, then right ventricular hypertrophy is seen. And with right ventricular hypertrophy, then later over the course of time, pulmonary hypertension can develop.
No, initially straight we go to the hypertrophy?
No, sir, first right ventricular enlargement will be seen. Over the time, then the muscle wall of the right ventricle will also increase. So right ventricular hypertrophy will be seen.
What is QP-QS ratio? You uttered somewhere in between 1.5. What is that?
So QP-QS ratio is the ratio of the pulmonary vascular resistance raised to the systemic vascular resistance. In a left to right shunt, if the QP-QS ratio is less than 1.5 raised to 1, then it is then intervention for the same case can be done. But if the ratio increases, that means that the shunt would reverse, and then the treatment course would become difficult.
Are you sure?
So over time, the shunt
with
will reverse.
Ratio, a 30-year-old, 35-year-old patient with QP-QS ratio of 1.3 versus a patient of 35 years, everything same, with a QP-QS ratio of 2.5. Which patient is a good patient to operate and which is a bad patient?
So the younger patient is a good patient to operate.
Both have same age. One has QP-QS 1.3 and one has QP-QS of 2.5. So
1.3 is the patient with 1.3 QP-QS ratio is a good patient to operate.
No, I think you're wrong on that. It means you have not understood what is QP-QS ratio.
It is the ratio.
It is
the ratio of pulmonary blood flow to systemic blood flow.
Normally the QP-QS is 1. Whatever the blood goes to the systemic circulation, that same goes to the pulmonary circulation. But in a patient of ASD, there is more pulmonary circulation because there is circulation through the ASD or any left to right shunt. So all these patients have got more pulmonary circulation than the systemic. So QP becomes more. So they have got more QP than the QS. The QP-QS ratio is more. But over a period of time, they develop pulmonary hypertension, and the pulmonary circulation is restricted by the pulmonary hypertension, and the flow goes down. But still, because of ASD, they have got more flows. A stage reaches when the pulmonary circulation becomes lesser than 1.5. I mean, if it's 100 ml to the systemic, the pulmonary is less than 150. It means there is development of pulmonary hypertension to a level that it is not allowing the extra blood to flow to the pulmonary circulation.
To the shunt and
No, you just listen to me.
Yes, sir.
So a stage reaches when the pulmonary circulation is less than the 1.5 of the systemic circulation, and coming to the third, fourth decade, at this stage the right ventricle starts failing. It cannot generate enough pressure that it can push more than 1.5 of systemic circulation to the pulmonary circulation. It means the patient who has got a QP-QS less than 1.5 is inoperable or is a difficult case to handle because PAH is so high that this patient is going to trouble you even if you correct the ASD. Okay. So more the
Yes.
QPQS, easier it is. It means the pulmonary
Better.
hypertension is not yet set.
Okay.
Okay, you'll remember it for always now?
Yes, sir.
Okay.
Yes, sir.
I think, do we close it because it's already more than an hour or so?
No, we have 10 more minutes to go. Okay, fine. Vaishali, you want to ask something?
Okay.
How are you going to... Okay,
Yeah,
okay,
madam, go
ask
ahead.
us.
Madam, yeah, no, go ahead, madam. No doubt.
Okay, I want to know how you are going to decide this patient can come for ASD device closure or this patient need the surgical correction.
Ma'am, for an ASD device closure, the device should have a proper rim to sit on. In this case, on a 2D echo, an ostium secundum defect of approximately 10 millimeter in size was seen in the 2D echo. So in this patient, a device closure in a cath lab was a much easier option available, which could have been done because there was a 5 millimeter rim present on each side, and the device could be lodged in it. But for in other lesions where the rim is not sufficiently available, then surgical, or the septal defect has a larger size, then a surgical management is followed.
What are the different types of the devices are available for device closure?
Yes, ma'am. There are different devices available. The device that we used was as per, just a second, ma'am.
Probably that will be too high for a MD student.
No,
What
she
type
did.
of
She did
anesthesia?
the
Okay,
case.
what type
So
of
she did the
anesthesia?
case recently. That is why I'm asking. She's aware of all the questions.
There are different devices available, ma'am, like a Angel Wings device or a Cardio Seal device and an Amplatzer septal occlusal device. So we made use of a Amplatzer septal occlusal device first.
Okay. Then what type of anesthesia would you like to give in a 4-year-old child?
Ma'am, we would
For device
always
closure.
advise for a
For
general
device.
for device closure, ma'am. We would advise for a general anesthesia to be given to this patient so that movement in the procedure is avoided. Also, if the patient coughs or is there any resistance seen, there will be increase in resistance, which would further lead to dislodgement of the device, would disturb in the procedure. So a general anesthesia is always preferred.
Okay. What type of tube will you use?
Ma'am, endotracheal microcuffed tube.
And size?
Why you want to use micro cuff tube in this case?
Microcuff tube, there will be lesser resistance to the cuff is seen. Decreased chances of laryngospasm or bronchospasm are seen, and has
Are
a
we
good
worried for that or we worried for something else?
Something else, yeah.
lesser traumatic.
You are going to do this case under TE guidance?
They are putting TE,
Yes, and
na?
also after, yes, ma'am, we can put a TE also if we put a.
They will put it only. They will put a TE.
In most of the places, these cases, 4-year-old child with the ASD for device closure, it is done under TIVA with the intravenous anesthesia without ET intubation.
So we did the case in TIVA only. Case was completed in half an hour.
And TE is not, none of the cardiologists need a TE nowadays because they do transthoracic. 3D transthoracic is good enough for them. For the ASD devices, mostly they don't use TE. They have got the, and 4-year child, TE pediatric probe is hardly available in a limited, you can count on fingers the centers have. So the transthoracic, maybe 3D or 2D, and total intravenous without intubation and with oxygen mask, it goes smooth, probably, most of the places where I've seen.
So if you are going to do it under total intravenous, which drug will you prefer?
Ma'am, fentanyl and ketamine both were used in this. The induction was done with doses of fentanyl, ketamine, and maintenance was done with fentanyl infusion.
Any other drug?
Ma'am, we'll start with glycopyrrolate, midazolam pre-medication.
Nowadays people are using newer drugs. Which?
Can we use remifentanil?
Remifentanil.
Yeah.
Remifentanil can we use?
Okay.
What are the precautions we are going to take while doing this case?
Ma'am, for all precautions in a pediatric case were taken. Proper temperature was maintained. Warm fluids, warm table was mentioned. Or
Especially
IV
in
fluids should be
relation to
given without
device,
bubbles. Yes,
especially
ma'am.
when you are doing the device.
No, we made sure there were no entry sites for the bubbles to go through. The IV lines were de-aired properly. Proper rate IV fluids were calculated according to the weight. No air bubbles were went. And also during the device, when they put the device was put under water. It was soaked in water so that no air enters via any pore.
And child should
this
not
was one of the
move
biggest
during.
concerns.
Child
Yes,
should
ma'am.
not
And the
move
child should
during
not
that
move
time.
during putting of the catheter. Yes, ma'am. So deeper plane of sedation was maintained.
Post-operatively, what will be your drug of choice for this patient who has got a device
Sir,
was done for ostium secundum ASD? What is your worry?
Sir,
Many times, if this patient goes into
CO.
pulmonary edema, what is your diagnosis?
There has been a dislodgement of the device and it's blocking the
Device is working
circulation.
properly. Device is at proper place. What
There's
could
a
be the
probable
cause?
leak which is causing
No,
pulmonary
there is no leak.
hypertension,
Device
further
is
pulmonary.
working. Device is perfect, but the patient has gone into pulmonary edema. What could be the cause? Okay, let me just explain you. One of the major criteria of ASD closure, maybe device, maybe by patch or maybe anyway, is the LA size. The left atrium is small because left atrium has got a low pressure chamber to eject throughout the life the patient has lived. Okay, so left atrium ejects into the right atrium and left ventricle. So it doesn't develop that big over a period of time what it should have been. Okay, so once you close that ASD, that's the reason most of the surgeons, they don't close directly, even if maybe the small 1 centimeter, 0.8 centimeter, they close with a patch. So if you close this, and when you close it to the device, there is no extension given to or extra volume space given to the left atrium. So after device closure, the small left atrium receives the normal blood, what it receives normally. And that blood may not be sufficient, or the LN may not be sufficient to receive that blood. And suddenly the left atrial pressure increase. The left ventricle in these patients is normally of small size, because there is recirculation locally from pulmonary to the cardiac structures. The left ventricle is small size. So that left ventricle and left atrium may not be able to receive the blood, which it was not habitual of. And when it's not receiving, it's not able to receive, the back pressure changes happen and that patient goes into pulmonary edema. So all these patients are put on pulmonary inodilators. Inodilators means, number one, they increase the heart rate a little bit from 90 to 100. And second thing, you give a peripheral vasodilation so that afterload is reduced. So any extra volume received by the LA or LV will be thrown back to the systemic circulation and they don't go into failure. So mostly what I remember in my KEM days, we used to put a lot of anti-G paste in patient's mouth or somewhere on the skin, or anti-G patch used to do. Nowadays, better drugs are available, Milrinone or dobutamine, all these are available. They were not there that time.
So I think we can conclude now, Rajesh. Vaishali, you want to ask
I'm
anything
waiting
else?
for you to say that.
Yes, madam.
You want to ask anything else or done?
No. We
So
are
just
beyond the level of MD anesthesia, and they have presented very well, very nicely.
All the best to
They
both
know
of
the
you.
subject.
Thank you so much, ma'am.
Thank
Thank you,
you.
sir.
Thank you, ma'am. Thank you, sir.
okay. So Uma, you can conclude now.
Ma'am is muted, I think.
Uma, are you there? That doesn't matter.
Madam,
It's okay, I'll take over. Okay. Yeah. Heartiest congratulations to both of them, Aditi.
Thank you so much, ma'am. Thank you.
Thank you very much, ma'am.
Thank you. Very well presented. Amit, you too.
Thank you very much, ma'am.
And I'm sure you both will do very well in your exams. This was a
Thank you, ma'am.
lovely,
Thank you, ma'am. Thank you.
lovely case discussion. And of course, with the examiners like MANJULA, Rajesh, and
Vaishali.
Dr. VAISHALI. I remember her surname very well. So VAISHALI moderated so well. Lovely question and answers and all the discussion. These were all the practical questions which are asked you in the examination. And as Rajesh said, the questions were well above the MD mark. So it means a lot. And thank you so much, Manjula.
Thank you,
Rajesh,
madam.
VAISHALI,
Thank you, ma'am.
and dear students.
Thank
And
you,
Thank you so
ma'am.
much.
hope to see you next Wednesday for another session.
Yeah.
Thank you.
Yes, ma'am.
Yes, ma'am.
Thank you. Bye-bye. Bye.
Thank
Thank
you,
you.
madam,
Thank
for
you. Bye, ma'am. Good
ICA
night.
to giving this
Bye, ma'am.
opportunity. Yeah.
Yeah.
Bye, bye,
Thank you,
everyone.
ma'am.
Bye-bye.
Bye.
Bye,
Thank you,
Sneha.
ma'am.
Bye.
Bye-bye. Good night.
Thank you.
Good night.
Thank you.
Thank you so much,
Bye,
everyone.
Uma.
So,
Good night, dear.
Bye, ma'am. Thank you.
Bye-bye.
so with all of your permission, can we end the session over here?
Please.
Thank you so much.
Thank you.
Thank you, ma'am.